The overview is pretty straightforward for the most part. Here's this device. It is expandable, and in doing so, it changes the shape of the footprint, maximizing surface contact to reduce subsidence risk. It really expands some 5 millimeters in 3 planes and increases the lordotic angle, so it goes from 9 degrees to 8 degrees, up to 9 to 8 degrees from 0. You get immediate stability. The threads engage the end plates, the buttress threads resist migration, and you get the really secure fixation anteriorly in the apophyseal ring, so a very strong part of the spine. And this results in long-term stability. The large fenestrations and in situ graft loading allow for a tremendous amount of bone to be in contact with multiple surfaces. And the titanium material meets the demands of biomechanical loading, and it's also very, very biocompatible with ongoing fusion. The instrumentation set is very compact and very efficient in its packaging and really contains all the things that you would need for both assisting with disc space preparation as well as safe implantation with circular neurological guides and all the instruments you need to safely implant the device once the disc space has been prepared without the trauma to neural structures. There are a variety of surgical approaches that are available as this is an implant allows the surgeon's choice, whether it's going to be open, mini-open, tubular, minimally invasive, or even an ambulatory surgery center. All these are at the discretion and available to the surgeon in accordance with the surgeon's expertise and preferences. The device is versatile. It's used either as standalone, as indicated, or it can be used with posterior fixation as deemed appropriate with either screws or with interspinous process stabilization devices. In the standalone application, the disc space preparation is key. Meticulous and thorough evacuation is needed, and preservation of the end plates becomes paramount to prevent subsidence and to prevent device migration. The surgical steps really start after the surgeon has exposed and approached the spine in a manner in which you're most comfortable for the given patient, and then the disc has been evacuated and properly prepared. At that point, the trialing step can begin. There are several trials which can be the usual paddle type distractors. Some go in with rotation, others just slide in. Once you've analyzed the overall height of the trial needed, this trial will allow then for insertion. The trial itself is threaded, and so it creates the beginnings of grooves in the spine, which allows the device to follow this. So the step 2, insertion of the device itself, it goes in and it's contracted condition, but requires no impaction. And so simple, gentle rotation allows the device to be inserted in the least traumatic fashion. And then once properly in place and placed anteriorly engaging the anterior apophyseal ring, is expanded. And with that expansion, the lordosis is created. There's additional engagement of that apophyseal ring anteriorly, but throughout the end plate, and then allowing this tremendous space. The graft is delivered through the implant itself once it's inside the space. Once that's accomplished, the end cap is placed to secure the bone. The loading device and retractors are removed, and basically it's closed per routine. The post-op protocol is likewise at the discretion of the surgeon. We all have our own protocols, and here's one such protocol that is not at all unreasonable for this device. 6 weeks of restricted activity. Obviously, the patient will be wearing the brace, advised to try and avoid heavy lifting, bending, twisting, or unnecessary bending, lifting, twisting. This can be prescribed for 6 weeks or even some 12 weeks in some cases where you feel that's necessary. It's always a 24 to 40-hour visit, or in the ambulatory setting, a televisit would be more than appropriate just to check on the patient. 2 weeks is the usual wound check, good well-patient check, see how things are going. Typically, x-rays can be obtained just to make sure that there's been no migration, no early changes in stability. And after 6 weeks, the brace is weaned, and after 12 weeks, x-rays secure or demonstrate security of the device. Physical therapy is started and resumption of normal activity as the patient is indicated.